This video is a guide to the process of extubation of a positive or suspected COVID-19 patient from the ward who has had surgery in ADHB operating rooms. It follows the checklists available in the auxiliary documents and should be used in conjunction with the perioperative COVID-19 guideline. Links to the associated documents are in the description below. Staff and patient safety are our priorities. This process is written in a way to lessen exposure to staff and to reduce contamination. The aim is to minimise the potential for aerosolization. The plastic drape acts as a physical barrier between the staff and the patient's respiratory droplets. All drugs and equipment that may be required during extubation and the 10-minute stand-down period should be available in the operating room. The red bell should not be pressed during this time. Therefore, a robust plan for patient management should be established. Closed-loop communication and speaking up is emphasised. The Extubation Brief checklist is available in the auxiliary documents. This brief is led by the anaesthetist and involves the technician and third nurse. This occurs after the patient has been moved back onto their ward bed.
Right guys, so now that we've got the patient over on their own bed, we'll talk through the extubation briefing and just talk about what our plan is going to be for airway management while we're taking out the tube. We want to make sure that we have the best chances to extubate the patient as smoothly as possible the first time, and so we're just going to take things slowly and carefully, the same as we did for intubation. We'll use closed loop communication, and if anybody sees anything at any point in time, please speak up, because this is a critical point in the airway management. So in terms of optimising the conditions, so far we've got the head of the bed at a slight angle, which is good, and the patient is well oxygenated, and we will plan to do what we can to minimise aerosolization. So contingency plan for coughing, we've got some remifentanil running already, and Kay, I've got some lignocaine drawn up there that I'm going to ask you to give at the same time as the Sugamidex later.
Great.
Okay. If the patient looks at all agitated or things aren't going smoothly, then we'll just have a low threshold to get the patient back off to sleep. We'll regroup and talk about what our plan will be to decide if the patient's suitable to extubate or not at that point. I do have some drugs drawn up here for reintubation and for emergencies, but if we've got any concern that this patient won't extubate smoothly, we won't extubate him.
And there's a bunch of them over here, and if you just instruct me what you want to get at the time.
That's a good idea. Great. In terms of recovery, I think we'll get Paku in to recover this patient.
Great, I'll give them a ring now to give them a heads up.
Oh, thanks, Lee. Does anyone have any questions or concerns?
Nope. Sounds clear.
Sounds good to me.
Great, let's get started.
The extubation process checklist is available in the auxiliary documents. This process occurs after the other operating room staff have doffed and left the operating room, and only the airway team remain. It is read by the nurse, who remains 2 meters from the patient and ideally parallel to or behind the patient's head.
Okay, I'm going to read some instructions aloud and then I'll pause for you to complete the action. If you can just acknowledge when the action is complete so that I can move on.
Sure.
Thank you.
Rubbish bin on the left within easy reach of anaesthetist.
Thanks.
Airway tray with face mask, Goodell and syringe on right side of patient's pillow.
That's complete.
Place the surgical and Hudson mask on left of patient's pillow and connect Hudson mask to oxygen supply, but do not turn on.
That's connected.
Suction airway if required. Resheet yanker and place under pillow.
We will suction the airway, thanks, Kate.
Suction's on. Okay.
Okay, so the airway is suctioned.
Technique for smooth emergence instituted. Reverse paralysis.
Okay, so we've got So remifentanil running as an infusion. Can you please give the 5 mils of lignocaine that are in that tray there?
Okay.
And then there's some Sugammadex there as well. Could you give 2 mils of Sugammadex, please?
So give it 2 mils.
Perfect.
Given.
Thank you. Was draft given.
Tech draws plastic sheet over patient's chest and head, covering anaesthetist's forearms.
Thank you.
When ready, anaesthetist instructs tech to turn off anaesthetic.
Could you turn off the SIVO now, please, Kay, and just turn the oxygen up to 10 litres at 100%.
That's confirmed.
Thank you. That's done.
Anaesthetist removes eye tape and tape from tube.
So the eye tapes are off. And the tube tape is released.
Tech switches machine to manual ventilation and opens APL.
Okay. Yeah, so we'll just wait a few minutes for the volatile to come off and just wait to be ready to take that tube out. Simon? Simon, can you open your eyes for me? Simon, open your eyes. Okay, so we'll turn the ventilator off now. Can you check the APLs open?
Ventilators off. APLs on minimum.
Perfect, thank you. We've done that, Celine.
When ready, anaesthetist deflates cuff. ET tube is removed and placed into dirty tray on patient's right. Face mask is immediately applied using two-handed technique.
Great. Simon, can you just take some big breaths in and out for me? All right, you're doing really well with your breathing. We're just going to take that breathing tube out of your mouth now. Just deflating the cuff now. Just pulling that out of your mouth. Well done. Okay, so we're extubated and I've got the oxygen mask on.
Face mask is held in place and the patient's respiratory status is assessed.
Just breathe in and out, Simon. Everything's gone very well. Looks like he's breathing well there. What do you think?
Good trace up there.
All right, looks like he's doing well there, Celine.
When appropriate, face mask is removed and placed with filter into dirty tray under plastic drape. Tech ends case on ventilator.
Thank you. That's done.
Apply surgical mask. Hudson mask to be placed over surgical mask. Turn on auxiliary oxygen supply.
Just putting this different mask on your face, Simon. That's great, so we've got both masks on the patient.
When ready, tech slowly and carefully lifts plastic sheet from centre while anaesthetist picks up dirty tray. Plastic sheet is carefully folded in on itself by anaesthetist enclosing the tray and immediately placed in bin with minimal folding.
That's complete.
Remove outer gloves, perform hand hygiene and re-glove. Ten minutes stand down begins now. I will start the timer. Suction is left in place under pillow. Reminder, after patient leaves room, suction is turned off and disposed of intact with canister.
Great, thanks everyone.